Thank you, Chairman. No conflict disclosure. It has been reported that the effectiveness of new generation cytotoxic agent for advanced non-small lung cancer is equivalent. And also it has been reported that PEME and S1 are not inferior to first-line chemotherapy for advanced non-small lung cancer. So, an appropriate chemotherapy menu using taxane, PEME, S1, and gemcitabine can be selected for any individual on the basis of biomarker status without any disadvantage. We reported that patients with CN23 non-small cell lung cancer with simultaneous low expression of ERCC1 and tubulin were promising candidates for surgery after carbotaxane chemoradiotherapy. The expression of tubulin, RRM1, TS, was a significant prognostic factor in those cases. In our last study, there were a number of limitations. Firstly, it was retrospective and the biomarker status indicative of a pathologically complete response could not be identified. Secondly, all patients in the last study underwent carboplatin taxane induction chemotherapy. So, the real significance of TS and RRM1 status on predicting patient survival was unclear. So, purposes. Although there has been considerable progress with targeting therapy and the new generation cytotoxic agent, surgery is still one of the best potentially curative therapeutic options for non-small cell lung cancer. If best chemotherapy menu for an individual can be selected from biomarker status of tumor, salvage operation for cure may be possible. So we conducted a prospective study. We tried chemotherapy on the basis of biomarker examination for initially unresectable non-small cell lung cancer patients. For patients who exhibit good PR or CR, operation was tried. 25 patients with pathologically proved non-small cell lung cancer initially diagnosed as unresectable were enrolled. The reasons for unresectability were 13 bulky N23, 2 chest wall and vertebral invasion, 2 tracheal invasion, 2 single brain metastasis, 2 lung metastasis, 2 poor lung function, 1 adrenal metastasis, and 1 atrial invasion. Again, I tried chemotherapy on the basis of biomarker examination for initially unresectable non-small cell lung cancer patients. For patients who exhibit good PR and CR, operation was tried. The strategy for each unresectable reason. For bulky N23 diseases, mediastinoscopy was done for pathological confirmation. For single treatable brain metastasis, gamma knife was performed and complete response was confirmed. For lung metastasis, batch biopsy was performed to confirm pathologically complete response. For adrenal metastasis, laparoscopic resection of affected adrenal was performed. So this is a criteria for drug selection. Regardless of biomarker status, application of platinum doublet therapy is mandatory. Patients with low beta tubulin carcinoma will receive platinum and docetaxel. Next, patients with low TS non-squamous cell carcinoma will receive platinum and PEME. Next, patients with low TS squamous carcinoma will receive platinum and S1. Next, patients with low RRM1 carcinoma will receive platinum and gemcitabine. If possible, bevacizumab will be administered in patients with non-squamous cell carcinoma. If possible, concurrent thoracic irradiation. So 25 patients, stage 3A, stage 3B, stage 4, and histology is adenocarcinoma 12, squamous cell carcinoma 11, other 2. So this is the antibody and adjustment. Our sample was classified according to our scoring system. This is the result. According to the protocol, platinum plus dose was administered in 15 patients. Platinum plus PEME was administered in 6 patients. platinum plus S1 was administered in 5 patients. And according to, at regard of response to induction therapy, partial response, good partial response was exhibited 21, and in 21 patients, complete resection was performed successfully without major morbidity or mortality. Pathological effect of induction therapy, complete response in 4, major response 10, minor response in 7. This is a summary of a result. Post-operative biomarker status was markedly changed in most cases, and 10 patients received adjuvant chemotherapy on the basis of post-operative biomarker status. Response to induction chemotherapy, there are no difference between the different regimen. Pathological effect of chemotherapy, also there is no difference between the different regimen. Stage down, we achieved 16 out of 20 operated patients, stage down achieved. This is the overall survival of 25 patients after induction therapy. Induction chemotherapy plus surgery, 2-year survival of 65.3, and chemotherapy only 37.5. There is a difference between groups. Overall survival of 20 patients treated by surgery after chemotherapy in latent pathological effect. Complete response show the best survival. So summary, 21 initially unresectable non-small cell lung cancer patients received chemotherapy on the basis of biomarker status of tumor. 21 of the 25 patients with PR underwent complete resection successfully without major morbidity or mortality. With regard to the stage, 16 out of 21 operated patients achieved stage down after chemotherapy. The 2-year survival rate was 58.7 for the 25 patients overall, 65.3 for patients underwent surgery after chemotherapy, and 37.5 for patients without surgery. So this is a limitation. There is a small number of study and observation time is so short. Canadian consensus recommendation reported that there is insufficient evidence of ERCC1, beta-tubulin, and RRM1. And also Burton reported ERCC1 expression is not associated with response and survival after platinum-based chemotherapy regimen in advanced non-small cell lung cancer. And also reported the differential expression of biomarker in primary site and metastatic site. In spite of this negative background, in conclusion, chemotherapy followed by surgery on the basis of biomarker examination appeared to be a promising strategy for patients with initially unresectable non-small cell lung cancer who otherwise might have a poor prognosis. This tailor-made strategy may open a new avenue for treatment of patients who were previously considered incurable. Thank you.
We'll open the discussion with a question by Dr. Jones.
Yeah, David Jones from Virginia. I congratulate you on a nice study with a very challenging group of patients. I had just a couple comments. One maybe is semantics, but most of these patients probably were not unresectable. You may have thought they were inoperable or that operating may have been a bad idea, but it struck me that probably most were resectable, so that's just a small point. How many of the patients had radiation as part of their induction strategy?
Yes, 19 patients.
19.
Out of 25 patients.
Okay. And what were some of the operations that you did? I may have missed a slide on that. And how many were you actually able to achieve an R0 resection?
21 patients, all 21 patients, R0 operation was performed successfully.
And did this require, a concomitant or non-block vertebral body resection, or what were some of the other operations that you did?
Yes.
How many of these patients, for instance, had a pneumonectomy?
Pneumonectomy, 2 pneumonectomy.
This is a very interesting population, and I'm curious as to whether you've done EGFR mutation testing on this population, and whether the majority of these patients or the minority had mutations, and whether that was factored into these responses. Do you have mutation testing on these patients?
Yes, of course. EGFR mutation, you mean?
And just out of curiosity, was there any correlation between response and mutation status?
Yes. From our last result, mutation means ERCC1 or no.
I was talking about EGFR.
EGF mutation.
Yes.
Yes. We checked in all cases.
Right. And then is there any correlation between the patients who had?
I'm sorry. I didn't study.
Okay. Other questions?
Tom Waddell, University of Toronto. Hiro, I enjoyed that presentation very much. The question I have is about the comment Dr. Jones made about inoperable patients. So you listed solitary brain mets, adrenal mets. I think that is considered a population which some other groups might consider operable. It's a controversial point. What is the upper limit for entrance into your study? If you will accept patients who have lung metastasis, does it have to be solitary? Will you accept patients who have lung metastasis and adrenal metastasis? In the oligometastatic patients who are considered inoperable because of metastatic disease, what will you accept?
Thank you for that's an exciting comment. That means lung metastasis PM1, PM1, and that is a upper limit. You mean so? Inclusion criteria, upper limit, you mean?
Yeah, it seems that some patients entered your study because they had metastatic disease. So what defines acceptable metastatic disease to enter the study? Does it have to be only a solitary met in a single site?
Yes, same site singles, and also single brain treatable metastasis, and a single adrenal metastasis. That's upper limit.
Any other questions from the floor? And then I want to thank my co-moderator, thank Dr. Yokomise, and the audience for a wonderful session.